Right. I'm seeing a slowing of people entering the waiting room. So, in the interest of time and respecting everybody's time who was able to log on right at 11, we'll go ahead and get started. Welcome to the Baker Center's September offering in our educational seminar series highlighting important topics in child and adolescent mental health. This series is funded in part through a grant from the National Child Traumatic Stress Network and the Substance Abuse and Mental Health Services Administration, or SAMHSA. The Center for Effective Therapy at the Baker Center is a mental health clinic specializing in short-term evidence-based treatments for the most common mental health issues facing children, adolescents, young adults, and their families. And the goal of this series is to increase access to effective, high-quality mental health care for children, adolescents, families, young adults, especially those impacted by trauma or other stressful events in their lives. My name is Sarah Gurney. I'm a senior social worker at the Center for Effective Therapy. I work out of our Waltham office. I've been working with kids and adolescents for over 15 years in a variety of settings, so school-based, um, home-based, community, residential, kind of all over the map, and have been working with kids, adolescents, and families throughout my career with a primary focus in evidence-based treatments for children, teens, and their families, especially for kids and adolescents who are struggling with depression, anxiety, suicidal ideation, and self-harm. Please hold your questions for the end. If you have questions that are coming up, please feel free to type a question into the chat or message it directly to Alex, who's my co-host today, and we will answer them in the order we received them at the end of the presentation. I'm not able to see the chat and see my slides at the same time, so don't want to try to split my attention and not be able to give you the full scope of the presentation. Speaking to the scope of that presentation, I won't be able to speak to individual circumstances or give personalized recommendations in this setting. If you do need individualized support for yourself or for a young person who's struggling in a non-urgent situation, please reach out to us at the Baker Center. We can help you identify the most appropriate level of care, which might be coming to us for assessment and treatment, or might be a recommendation for more intensive supports in the meantime. For more urgent needs, please reach out to your local community behavioral health center, the behavioral health helpline, your primary care doctor, or 988 for help. And we'll go over some of those resources in more detail as we go through the chat or through the talk so that you know what resources are available to you in a more urgent situation. As a note of caution, this presentation does include sensitive and potentially upsetting topics, including self-harm, suicide, and other safety concerns that can arise when youth are struggling with their mental health. These are heavy topics. Oops, sorry. These, there we go. These are heavy topics and ones that are very close to my heart as a clinician and just as a person. And I'm going to approach these topics and these conversations with respect for those that are struggling with them. Because of that respect, I feel it's important to speak frankly about these topics and how to support those at risk, which means talking pretty directly about some of the risks that might face someone who's really struggling with their mental health. I encourage you to take care of yourself throughout this talk and throughout the day as you process this information, which might mean stepping out or seeking support for yourself if needed. For our agenda today, we're going to start by talking about depression in teens and depression in children and how it can differ somewhat in what it looks like compared to our typical conceptualizations of depression. We're going to talk about self-harm and suicidal thoughts, which are risk factors, risk concerns that can come up when kids are struggling with depression or with other mental health needs. We'll talk about risk factors for suicide, things that put individuals at a higher risk for having these thoughts or for acting on these thoughts. And we'll talk about safety planning with adolescents when these thoughts are coming up, how to respond to a child in a crisis, proactive steps you can take to keep an environment safe for a young person who is currently struggling. And we'll talk about increasing protective factors to help kids heal. So speaking of depression, The core symptoms of depression are a persistent low, sad, down, depressed, or irritable mood most of the day, every day, or diminished interest or pleasure in previously enjoyable activities. So someone who is really feeling not like themselves, they're down, they're irritable, everything's bothering them, and or things that they usually find pleasure and enjoyment in just don't seem to hit the same way. And accompanied by these related symptoms, feelings of worthlessness or guilt, difficulty concentrating, fatigue, agitation, which means like restlessness, trouble sitting still, or conversely, a slowing of movements, feeling almost like you're moving through molasses, appetite changes, sleep changes, and recurrent thoughts of death. When we talk about depression, we're typically referring to major depressive disorder, which is defined by major depressive episodes. Those are periods of 2 weeks or more where a person is showing depressed or irritable mood most of the day, every day, or that loss of interest or pleasure in previously enjoyed activities, accompanied by some of these related symptoms. But major depressive episodes also occur in bipolar disorder, and depressed mood that doesn't meet that threshold for a full major depressive episode can still be incredibly painful and difficult to manage. Our cultural conceptions of depression often look like antidepressant commercials, these sad people living in grayscale worlds. But depression in kids and teens can look a lot more like irritability, refusal, defiance, refusing to go to school, withdrawal from previously enjoyed activities, snappishness, complaining that nothing is fun, everything is boring, they don't want to do anything. So it can look more on the outside like oppositionality or defiance or refusal coming from this low mood. Depression in adolescence is more common than people probably expect. This is 2018-2019 data. About 15% of adolescents on a survey that did not ask, have you had a major depressive episode, but asked about the symptoms of a major depressive episode, 15% reported symptoms consistent with a major depressive episode within the last year. And over a third reported experiencing persistent feelings of sadness or hopelessness. So even in the absence of a major depressive episode, these mood symptoms can be really getting in kids' way. Nationally, about 6% of adolescents ages 12 to 17 and 2% of kids ages 6 to 11 have been diagnosed with depression by a physician or a mental health provider. But we know that that only covers kids who have seen a physician or a mental health provider, who have disclosed the things that they're struggling with, and who have seen someone who was well versed enough in these symptoms to be able to identify what was going on. So we know that those numbers are an underreporting of how much kids are actually struggling. Depression is multifactorial, meaning there are many contributing factors for any given person with depression, but some risk factors include sensitivity to unhappy mood states. So kids that are more easily irritated, upset, or saddened than others. Anxiety disorders, feeling unable to cope with bad situations, stressful experiences, and negative thought patterns. All of those are kind of ways of thinking or pre-existing conditions that can predispose someone to developing a depressive disorder. Next, we're going to talk about some of those risks associated with depression. So the first risk we're going to talk about is something called non-suicidal self-injury. So this is intentional physical harm that's not intended to be lethal. So this is someone who's engaging in an action that is harmful to their body, such as skin cutting, head banging, hitting their head, burning their skin, not with the intention of suicide, not with the intention of this action resulting in their death. Research indicates that self-injury is best understood as a maladaptive coping strategy. Most commonly, people report that self-injury is in response to overwhelming negative emotions, emotional pressure, numbness, sadness, with self-injury providing a way to manage intolerable feelings or to experience a sense of feeling in response to that numbness. Other people might describe it as a way to cope with anxiety or other negative feelings, to relieve stress or pressure, to exert control over themselves, to distract themselves from other problems, or because the endorphins produced in response to injury help them change a negative emotional state. Many people describe it as a way to avoid suicide by changing an intense negative emotion. People who are experiencing self-injury or struggling with self-injury are at higher risk for suicidal thoughts or for acting on suicidal thoughts than people who are not experiencing self-injury. But that doesn't mean that self-injury itself is a suicide attempt. Most people who self-injure hurt themselves in more than one way. So they may engage in cutting of the skin and in bruising or punching things that could cause injury to their bones or the bones in their hands. Or they might engage in burning and also cutting. So it's not uncommon for people to self-injure in more than one way. And if we know that someone is self-harming in one way, it's important for us to ask broad questions about, are there any other ways that you have intentionally hurt yourself before? Most people who engage in self-harm start between the ages of 12 and 15. So in that like middle school to early high school age. But there are cases where that starts younger, and there are cases where that now starts older into later adolescence or adulthood. Excuse me. About 12 to 24% of high school students and young adults report that at some point in the past, they have had at least one incident of harming themselves on purpose. Of those, 1/4 only did so once. And 6 to 8% of adolescents and young adults who are surveyed report that they are currently engaging in self-harm. So this is an ongoing problem for them versus something that happened in the past or something that has happened one time and then never again. The next risk we're going to talk about related to depression is suicide. I want to make a differentiation here about our language. So notably, our thoughts are not our plans, and our plans are not our actions. A person may have suicidal thoughts that are not the same as having a plan to act to harm themselves or to end their life. And having a plan to end their life does not necessarily translate one-to-one into taking action. These each confer a higher level of risk. So this graph represents data from 2021 on the prevalence of suicidal thoughts, plans, and attempts in high school students, with the green bars representing girls and the blue bars representing boys. The data are separated by assigned gender, and trans youth are not represented separately in this data set. Of note, trans youth are at higher risk for suicide attempts than cisgender youth. Girls are at a higher risk for suicide attempts than boys, and some demographic groups, especially Native youth and LGBTQ+ youth, are at higher risk than the majority of the population. But what this data shows us is more people have thoughts of suicide than ever seriously consider suicide. More people consider suicide than actually make a suicide plan. So come up with the when, the where, the how. More people make that plan than actually follow through with an attempt. And more people attempt suicide than actually die by suicide. So while, again, each of these confers an increased level of risk for that person's immediate safety, there's kind of a gating here where a person's suicidal thoughts do not automatically mean we are in an emergency situation. So we're going to talk about how to differentiate the urgency of some of these thoughts. There are a number of risk factors that can be present for a given individual that increase the risk of them having suicidal thoughts or acting on suicidal thoughts. In terms of mental health and mental state, depression and other mental health problems, alcohol or drug use, feelings of social isolation, nightmares and insomnia, agitation, irritability, hopelessness, a perception that circumstances cannot be changed, and traumatic experiences can all increase risk in the moment. In terms of physical factors, chronic physical pain or other medical problems and insomnia can increase risk. Environmental factors that confer an increased risk include difficult life situations like abuse, bullying, and poverty, access to lethal means, such as having firearms in the home, legal involvement, such as a recent arrest or facing incarceration. Social factors include experiencing prejudice and discrimination, which specifically increases risk for LGBTQ plus youth, and family rejection. At the community level, communities with high economic distress, social isolation, weak firearm safety laws, and high rates of firearm ownership have higher rates of adolescent suicide. And suicide rates are also higher in Indigenous communities that are typically impacted by things like economic distress, social isolation, poverty, and a variety of other historical and current factors that increase risk for folks in those communities. In terms of relationships, the loss of a relationship such as a breakup with a partner or the death of a loved one temporarily increases risk. And trauma history, including experiences of bullying, abuse, neglect, sexual violence, intimate partner violence, and family separation, all increase risk for an individual to have these thoughts. I'm going to talk a little bit more about those specific mental health risk factors. About 20% of the US population has a diagnosable mental illness in any given year. So obviously that doesn't mean that every single one of those people is at a higher risk of suicide than the average person. Depression is the most common mental health risk factor for suicide, with substance use, including substance use disorders, being the second most common risk factor. Alcohol misuse or dependence increases risk for suicide by a factor of 10, and injection drug use increases risk by a factor of 14. So if you are aware of someone, if your child is struggling with both depression and substance use, that significantly increases their risk. Alcohol intoxication, so currently being intoxicated, is present in about 22% of all deaths by suicide, including adolescents and adults, and 30 to 40% of attempts. And opiates are present in 20% of suicide deaths in adolescents and adults. So those are very much things that we want to be getting folks into treatment for if they're experiencing substance use disorders. Post-traumatic stress disorder, bipolar disorder, schizophrenia, and borderline personality disorder all also increase risk for suicidal thoughts. When we consider the relative risk of these different types of suicidal thoughts, not all thoughts of suicide confer the same amount of risk for an individual. These steps on the continuum here are in escalating order of risk, with thoughts of death being the least risky of these categories. Thoughts of death include things like, I wish I'd never been born, I wish I could go to sleep and not wake up, I wish I could just be dead without acting to cause harm. Thoughts of suicide mean thinking about doing something to end my life. Thoughts of method mean I'm thinking about a specific thing I could do to end my life. So I have an idea in my head of an action I could take. Intent means someone is having thoughts of suicide and wants to act on them. So sometimes a person may have a thought of suicide or a thought of a method even that comes into their head that feels intrusive, uncomfortable. I don't want to do that thing. Other times people may have those thoughts and there is some intent of that thought feels comforting. I do think that I would feel better if I did that thing. Plan means a person has started to work out the details of a plan to kill themselves. So what they'll do, when and where they'll do it, and intends to carry out that plan. And action means someone has taken steps to act on their plan. So they may be collecting means, they may have obtained a gun, They may have started doing things like giving away valuables, writing a will or a suicide note, or practiced the actions that would be involved in a suicide attempt. Those last two there, plan and action, are emergency situations. So this is the time to contact emergency mental health services, which we're going to detail later on in the presentation, for a mental health crisis evaluation, or to go to your nearest emergency room. This is a person who is at immediate risk of doing something irreversible. If your child, whether this is a child in your home, a child who quote unquote belongs to you, or a child you're working with as a clinician, as a school counselor, has a history of suicidal thoughts or actions, the best time to make a safety plan is before another crisis happens. A person who's currently in kind of an okay headspace can think about what's going well in their life. What supports do they have? What are their goals? Who are their connections, in a way that they're not able to access when they're overwhelmed with despair. So how do you start that conversation? Because that is a scary thing to start talking about. I've got some example language here. You might start this conversation by saying something like, I'm so glad that you've been feeling better lately. You've been able to get back to spending time with the family, or going out with your friends, or attending your sports games, whatever it is that they enjoy doing, or positive things that are going well for them in this moment. I want to talk with you about making a plan for how we can help you and how you can help yourself if those thoughts of harming yourself come back. One of the biggest risks for suicidal thoughts is someone who has had a history of suicidal thoughts. If our brains have gone to that dark place before, it is more likely that they will go to that dark place again. So it's best to have a plan in place for how to cope with those thoughts in case those pop up again in the future. A safety plan can and probably should include these 7 sections. They don't have to be labeled exactly this. They don't have to be laid out in exactly this order. But this is a safety planning process that's supported by the evidence. So some of the research that's out there has been done by Dr. Stanley and Dr. Brown, which resulted in something called the Stanley Brown Safety Plan. It's an evidence-based strategy for supporting someone who is currently experiencing thoughts of suicide or has a history of experiencing thoughts of suicide to actively engage in their own safety planning and be a part of that process. And it involves identifying individual warning signs, identifying coping skills that that person can use that increases positive mood or positive feeling in the moment, distractions that can get their mind off of those thoughts when they feel overwhelming, people that they can ask for help, professional supports who can step in to help maintain safety in the moment, strategies for making the environment safer for a person when they're actively struggling, and emergency contacts. We're going to talk through each of those areas. The first step in a suicide safety plan is identifying predictors and signs of a suicidal crisis. Common triggers or predictors of a suicidal crisis include escalating interpersonal conflict, cessation of psychiatric medication, so stopping medication that is supporting our mental health, especially suddenly and without seeking medical advice, a recent discharge from a higher level of care, such as a hospital, to a lower level of care, such as being discharged from the hospital and going to a partial or home-based services or back to your outpatient therapist. Common language in medical settings differentiates signs versus symptoms. Symptoms are things that a person experiences, like racing thoughts, upset stomach, depressed mood, fatigue. And signs are things that an outside person, such as a medical provider or a family member, can observe. Something like increased physical movement, pressured speech, so speaking very quickly, and visible injuries. When talking with someone who's at risk about their warning signs, we want to include both their internal experience and what other people might observe. So some ways to phrase this are when you've experienced suicidal thoughts in the past, what was happening? How do you know when suicidal thoughts might come up for you? Or how might someone else know when you're experiencing suicidal thoughts? These are some common warning signs which may or may not apply to a given individual. So, someone who is making statements about suicide or wishing to be dead, writing suicide notes or plans, making final arrangements such as what they want done, um, what they want done with their body after their death, or what they want done with their belongings, and changes in behavior, appearance, thoughts, or feelings, which is very broad. But things like sleeping more or less than usual, a sudden change from a low or depressed mood to seeming upbeat or hopeful without a clear reason. Sometimes that can mean that a person is feeling hopeful because they're expecting a light at the end of the tunnel. They're expecting their pain to end soon, and withdrawing from people or things that they usually enjoy. Again, these might not be warning signs that apply to a given individual. These things are going to be really, really individualized. Our next step is identifying strategies a person can use independently to improve how they're feeling, even just a little bit. It's important to emphasize that these strategies aren't going to fix the problem that resulted in the crisis in the first place. They're strategies for surviving the crisis so that we have the opportunity to fix these problems in the future. Some people respond well to using a scale here. So identifying things that would take you from a 10 out of 10 level of distress to an 8 or a 9, like just get it a little bit more manageable feeling. And some people respond well to a time limit. Could you use this skill for 5 minutes or 10 minutes and then move on to the next skill or move on to the next step in your plan if that skill isn't getting you where you need to be? So these are internal coping strategies, things a person can use on their own without having to ask for help. Not because we don't want to offer support and help them, but because asking for help is really hard. And we want people to know that they can access these things on their own and then ask for help at a later step in the plan. Step 3 is people and places that can distract us from thoughts of suicide and get our minds off of those thoughts. So this may or may not be people that we feel comfortable saying, hey, I'm not doing okay. I'm struggling. I'm not feeling safe. This might just be somebody that I talk to them and it gets my mind off of my problems temporarily. And we can think really creatively here. This might be physical spaces and real life people, or it might be virtual people and places. Discord groups, Tumblr friends, recovery spaces online, drop in chat groups, anyone where speaking with them gets our minds off of the thoughts that are overwhelming for us in this moment. And we might want to ask the person, how can we help you to use your supports in a crisis? How can we make sure that these things are accessible to you? And do you feel comfortable letting this person know that they're a crisis support for you? Is this something that you just know internally? I can reach out to this person. They're typically available and we'll chat and it'll make me feel a little bit better, even if I'm not asking for help. And is there anything they need to know in order to support you? Step 4 is people you can actually ask for help in a crisis. So these are people that we would contact and say, I'm not doing okay. I need help staying safe. I'm really struggling. And we can ask questions like, which of your family, friends, or other supportive adults could you contact during a crisis? If we're the parent guiding this conversation, obviously we're hoping that we're going to be one of those supportive adults. But sometimes kids feel more comfortable contacting a grandparent, an aunt or an uncle, the parent of a friend, a school counselor, someone else as an intermediary who can then loop in the parent. We might phrase this as, who can you call when you feel stressed? How might you say it? What would you say to let them know that you're not feeling okay or that you need help staying safe? Step 5 is professional agencies. If your child is already working with a therapist, their office may have an emergency support in place, such as an after-hours emergency line, although many therapists and clinics do not. They're just not set up for that level of emergency on-call support. If your child doesn't have a therapist currently, or if their therapist doesn't have an emergency line in place, mobile crisis intervention, the behavioral health helpline, community behavioral health centers, which are physical locations, and crisis hotlines can all offer emergency support. And we'll talk again about each of those supports in more detail in a couple minutes. Step 6 is thinking about making the environment safer. When we think about reducing environmental risk, we want to consider both the highest risk items in the environment and any specific methods of suicide that a person has considered in the past or is considering. Oops. If your child has a history of attempting suicide or considering suicide via a particular method, such as an overdose on medication, restricting access to that specific method is crucial to their safety. Some of the highest risk items of people who die by suicide, the majority die by firearms. It's about 50%. So if there are firearms in the home, identifying those firearms and limiting access or temporarily removing that firearm can be a huge support in keeping someone safe in an emergency. Suffocation, including hanging, and poisoning, which includes drug overdose, are the second and third most common cause of death in suicide. So we want to think about ways to reduce access to potential hanging risks, medications, and other substances, including both over-the-counter medications and prescription medications. It may surprise folks to know that some over-the-counter medications can be fatal in an overdose. So even if you don't have any prescriptions in your home, but you have over-the-counter pain medications or over-the-counter allergy medications, those have a risk if someone were to overdose on them. So we want to make sure that someone does not have access to those in an emergency situation. So first, we identify what means are currently or potentially accessible to the person, and then identify how those items could be removed or how access to them could be restricted. So lock boxes, such as medication lock boxes that can be purchased from pharmacies, or lockable toolboxes that can be purchased from hardware stores, can be great options for limiting access to things like medications or other risky items. Whenever possible, firearms should be removed from the home if there's a person at risk for suicide residing there. If that's not possible, firearms should be stored unloaded and or disassembled, so in an unfireable state in a double locked location, such as with a cable lock and in a locked gun safe, with ammunition stored in a separate locked location. And if this is a proactive plan, because ideally, again, we're doing proactive planning, we want to practice. Like, if you have these items in your home, if there are times in your life when you are safe enough to self-dispense your medication, to take your medication independently, how could you ask your supports for help if you're starting to notice, like, I'm having these warning signs, I'm not doing well, I'm having some thoughts, I need someone to keep hold of my medication right now because I can't handle it. Step 7 is emergency contacts. So if someone is in an emergency, is going through this crisis safety plan, and they get to step 7, I've restricted my means, I've asked for help, I've tried to distract myself, I've used my coping strategies, and I'm still feeling unsafe, this is the time to contact emergency services. So 911, obviously we're familiar with. 988 is the suicide prevention hotline. So folks can call 988 and it serves similar to 911, where it routes you to your closest emergency services, and they will help kind of direct from there in terms of safety planning, assessment, getting folks to emergency services. You can also contact local mental health crisis or physically go to the closest community behavioral health center and request a mental health crisis evaluation. These are some crisis hotlines. So again, the National Suicide Prevention Lifeline. There's also a Spanish version. For folks who may feel more comfortable texting versus calling, the crisis text line is a great resource. The Trevor Project, which is a crisis intervention and suicide prevention for LGBTQ plus youth, has both a phone number and a text message number, as well as online chat versions. The Trans Lifeline is a peer support line for trans people, which is run by and staffed by trans people. They have some limited hours of availability because they're staffed entirely by those volunteers, but that can be a fantastic resource. And the National Alliance on Mental Illness Helpline, again, has some more limited availability, but is another wonderful resource. Once we've put together this safety plan with a person, the plan is only as effective as it is accessible and usable during a crisis. We want to keep this plan in an easily accessible location, such as a note in your phone and your child's phone, posted in a visible location in the home or in your child's bedroom. Copies can even be kept with supports. I know sometimes school counselors will say, like, how can I help a kid who's struggling with their mental health, who's coming to school? If they're struggling, what can I do? For them to have a copy of this safety plan can be really supportive. So in the moment, if we are seeing signs right now that a child is showing warning signs of suicide, talking about death, giving away possessions, withdrawing from others, or other warning signs that are specific to them, how are we going to approach them about it? First, I want you to stay calm and ask the question. It can feel weird to ask so directly. This might not be the very first thing you say in the conversation, but you want to make sure you ask directly the question, or a question like, are you thinking about suicide? We want to get comfortable using direct words, suicide, death, ending your life, because vague language like doing something dangerous, are you thinking about doing something dangerous, or are you thinking about doing something to hurt yourself, can confuse the situation. If someone is in so much pain that they're thinking about ending their life, they might not even consider suicide as harm because they see it as an escape. We want to stay focused on our concern for their well-being and avoid being accusatory. So you, as an adult who cares about this young person, are entitled to your feelings. You may feel hurt, confused, frightened, even angry, depending on kind of the context, what's happening here. In the conversation with them, we want to stay focused on our concern. We're not going to focus on how acting on suicidal thoughts would impact or harm others, because that's likely to make them feel worse. And we want to reassure them that help is available and they're not going to feel this way forever. If you get a yes, we want to listen to their story. How did we get here? What's leading to these thoughts? And accept and validate that they are struggling. This is not the same as saying, I think that the thoughts that you're having are the right solution to the problem. We're saying, I understand that you're hurting. I understand that this is really hard for you. I'm proud of you for telling me. I can see how someone who is feeling so hurt or so low might have those thoughts. And we want to listen for uncertainty. If they're willing to talk about thoughts of harming themselves, they're likely experiencing some level of uncertainty about acting on them. And we can help them identify reasons for living. What are they looking forward to? What goals do they have? What connections to other people are meaningful for them? What do they want to do with their lives? What is something in the future that they are wanting to do or engage with? If your child is experiencing thoughts of suicide with intent, so they are having thoughts of suicide and they want to act on them, or they believe that they will act on them, or a plan, so they are having thoughts of suicide with like, I'm going to do it on this day, or I need to get these things in place so that I can act. You want to contact the Massachusetts Behavioral Health Helpline or local mobile crisis, which we'll talk about in a moment, for a real-time clinical assessment, 24 hours a day, 365 days a year. You can call or text to this number, or you can chat online. Either way will get you a trained staff member who can help you access treatment and support immediately. If your child has done something in an attempt to end their life, even if that action is not potentially lethal, they're in an immediate mental health crisis and they need to be assessed so that your child and your family can work with professionals to keep them safe moving forward. Acting on a plan to end their life includes things like collecting means, like collecting pills, trying to access a firearm, saying final goodbyes, giving away possessions. This is someone who is getting ready to do something to end their life. Rehearsing includes actions like getting out the means and checking them over, practicing or starting and stopping a suicide attempt. All of these are absolute emergency situations, and we need to contact the local community behavioral health center, go to the nearest emergency room for immediate medical attention and psychiatric evaluation, especially if they have done something to harm themselves in an attempt to end their life. They may need medical attention to ensure that they are physically safe. So, community behavioral health centers are clinics that offer a range of mental health services for children, adolescents, and adults, and that includes emergency assessment. So, these are crisis services that are open 24/7 for walk ins with no appointment needed. You can just walk into the building. They try to be friendly and homey. You don't need health insurance to access them. Depending on the insurance you do have, if you do have insurance, you may have a copay, but crisis services are otherwise free other than any copay that might apply depending on your insurance. If you don't have insurance, they are still free. You and your child will meet with an experienced clinician in a private therapeutic space for a crisis assessment. And you can find your local community behavioral health center at this link here. So mass.gov/info details/find a CBHC. If you go to an assessment at a CBHC, you'll be meeting with a clinician and they'll ask questions like, what brought you in today? What are the challenges you're facing? How are these challenges impacting you? What does your support system look like? What do you need to feel safe? What do you think the next steps in your care should be? That doesn't mean they're asking you to make the plan on your own. They're there to support you, but they want it to be a collaborative process. In that assessment, the clinician will work with you and your child to develop an individualized plan to address your child's needs. Your clinician's goal is to help your child feel better now and prevent future crises. So that might mean helping to identify a therapist and making an initial appointment, introducing you to peer supports, helping to set up appointments for medication management, finding a bed at an inpatient mental health hospital if there's an emergency and this person is not able to return home and make safe choices for themselves in the moment, or getting your child into intensive outpatient treatment, such as a day treatment program where they're going to treatment for several hours a day, but they're coming home in the evenings and they're sleeping at home and it's not an inpatient setting. The other emergency crisis support I really want to plug is the Massachusetts Behavioral Health Helpline. This is, again, a 24/7 free confidential service that connects you directly to immediate clinical help for mental health needs. Their trained staff will assist you in determining what support best fits your child's needs and accessing treatment. And they can connect you with immediate mental health assessments, crisis services, substance use treatment, and referrals. And again, they're available through phone or text or an online chat at masshelpline.com. Again, as with the CBHCs, no health insurance is required. And because it's a telephone-based service and a chat-based service, real-time interpretation is available in over 200 languages, and deaf or hard of hearing folks can access through text or chat or via phone by calling Mass Relay. In terms of proactive steps we can take to make a home environment safer for someone who is struggling with their mental health, but is not in an emergency situation where they need to be seen and assessed and identify what level of care they need. We can think about alcohol, keeping in a locked location, such as a locked cabinet, or removing from the home temporarily. Alcohol is a risk for someone who's struggling because drinking can increase impulsive behavior, worsens depressed mood, reduces the ability to generate and implement alternative coping strategies, and can be involved in overdose attempts. Prescription or over-the-counter medication should be kept in a locked location, such as a medication lockbox, a locked toolbox, or another location the child or adolescent can't access. If your child takes medication and they're struggling with their mental health, we want to dispense it to them and watch them take it. Don't allow your child to keep medication in their bedroom. If you have opioid medication in your home, such as for pain management, take special care to keep this secured and keep emergency overdose reversal medication on hand. So that would be naloxone or Narcan. Firearms should be stored unloaded or disassembled, so non-functional state, in a double locked location, such as using a trigger lock, cable lock, locked gun safe, with ammunition stored in a separate locked location, or the firearm and/or medication can be removed from the home temporarily. Sharp objects such as razors, kitchen knives, pocket knives, hunting knives can be stored in a locked location, again, such as a medication lockbox or a toolbox. Hanging or strangulation risks, such as ropes or belts, can be removed from bedrooms, bathrooms, and other locations the child might be unsupervised. And if your child drives, talk with them about not driving when they're intensely distressed, because that could increase risk for accidents. Consider limiting their driving privileges temporarily. Assessing for safety in the home might include something called safety sweeps. So in those safety sweeps, a caregiver systematically checks the child's bedroom or belongings or even the whole home for potential hazards. We recommend this when warning signs for your child are present as part of making the environment safer for when their child is more vulnerable. We want to, oops, goodness. We want to look for risks. Oh, sorry. My mouse is wandering. Finding my spot again. Okay, we want to look for risks such as medication, alcohol, other substances, sharps, firearms, and hanging or strangulation risks. When possible, a safety sweep can be done with the child's knowledge and even with their help as a way to keep them safe, rather than something done in secret. Some kids and adolescents might even be able to communicate with parents or caregivers that they're struggling and ask for support in keeping these spaces safe for them. Protective factors are qualities, characteristics, resources that support safety and lessen potential risk. These include things like family support and good family communication, peer support and close social networks, connection to school and community, cultural or religious beliefs that discourage suicide, adaptive coping and problem-solving skills, which can be developed through therapy such as CBT, self-esteem and a sense of purpose, and access to effective medical and mental health resources, which is why I keep plugging Behavioral Health Helpline, the Community Behavioral Health Centers, Mobile Crisis Intervention, which is part of the Community Behavioral Health Centers. Those community behavioral health centers, again, they are one-stop shops offering emergency response, crisis evaluation, mental health services, and referrals to hospitals for care if needed. They offer something called mobile crisis intervention. They can come to your child at home, at school, in the community to do that crisis assessment and get them into whatever services are needed in the moment. If your child is at risk for opioid overdose, you can find more information about naloxone or Narcan for emergency overdose reversal at cdc.gov/stopoverdose/caring/naloxone.html. Or you can probably just Google CDC stop overdose naloxone and it'll get you there. As I mentioned, the Stanley Brown Safety Plan is an evidence-based brief intervention to help those experiencing self-harm and suicidal thoughts with a concrete way to mitigate risk and increase safety. And you can access that online. If you search Stanley Brown Safety Plan, it will most likely bring you directly to this resource, which is the Suicide Prevention Resource Center. And parents and educators can find more information about preventing adolescent suicide at this link here. I know it's hard to get a link during an online presentation, but these slides will be available on our website, so you'll be able to find it there as well. And then, as always, want to plug contact us for support, even if we're not the right emergency service provider, because we are not an emergency service provider, we may be able to point you toward the right intervention level for your child, whether that means helping you to access the community behavioral health centers, or if things are not as urgent, getting you into an assessment and treatment to really get at that underlying depression, anxiety, whatever's fueling these safety concerns. And I also have a couple of slides on my sources. I'm not just making this up. And thank you everyone for coming, for prioritizing this tough conversation. And we'll take any questions. Oh, I'm seeing a couple of questions in the chat. Fantastic. So first, is skin picking different than skin cutting in diagnosis? Yes, that's a great question. So sometimes they are co-occurring. So someone may be engaging in skin picking or excoriation disorder where they're compulsively picking at the skin. And someone may also be engaging in intentional self-harm. But skin picking is usually something called a body-focused repetitive behavior. So it's something that is more compulsive and outside of the person's felt control versus self-harm, which tends to be more of a like maladaptive coping strategy for managing overwhelming negative emotions or suicidal thoughts or things like that. So they can co-occur, but they're typically separate. And for recommendations for how to approach or support individuals with school refusal, that's a great question. Definitely depends on what's driving the school refusal. So is there something happening in the school environment that they're trying to avoid? Is it, I'm trying to get out of doing something that is unpleasant for me? Is it they're so depressed that they just can't get themselves out of bed and get themselves to school? So I would say starting with a really thorough assessment of what the drivers are for that behavior. And we also have a fantastic talk from, oh my goodness, I'm going to forget what month it was, but from this same series about managing school refusal from a couple of months back. So I definitely direct you toward that for like a more thorough overview of that. What would your recommendations be for helping individuals manage while EPS or psych evaluation or wait time in ER prior to assessment? That is a fantastic question. We are coming out a little bit of the worst of our mental health crisis, where I think folks are waiting in the ERs for days and days on end, a little bit less than they used to, but it's still a huge problem. Getting into these emergency services, getting into like an inpatient setting can still take a really significant amount of time. And it is such a challenge for folks who are like, I've been here for 6 hours, I've been here for 12 hours, for 36 hours, and I'm still not getting the help I need. So I would say, depending on what your role is, so if you're a caregiver who's with someone in the ER boarding and waiting for that assessment or waiting to get into that higher level of care that they're needed, doing what you can to try to distract them, to make sure that they've got things to occupy themselves. Because I think one of the biggest worries I have when someone is boarding at the ER waiting for a bed is leaving. So saying like, screw this, like I'm not waiting any longer, I can't do this, and just leaving that space, even though they're really in need of that emergency support. So doing what we can to try to keep them in that space. So reminding them, like, why did we come here in the first place? Like, we're really worried about you. We need to keep you safe. This is the right place for us to be right now. I know that's really hard. I know this is not where you want to be. And this is the right place for us to be in this moment. And trying to help them stay focused on like, this is how we're going to get help. This is how we're going to get to a place where we're no longer feeling this sense of urgency because we're no longer in this really unsafe emergency situation anymore. All right. Well, if there's no further questions, thank you again, everybody, for prioritizing this hard conversation. I hope you have plans to do something to take care of yourself today. I know it's not super sunshiny out where I am, but like get some physical movement, get some connection with somebody who you care for, get out of your head because this is a tough conversation. And I appreciate you being here and prioritizing being here for kids who are struggling. And yes, the slides will be accessible on our website. I think it usually takes a couple days between the presentation and when they get uploaded. And a recording of this webinar will also be available. So if you're like, oh, this wasn't on the slide, but I know there was something said that I want to refer back to, the recording will be there as well. All right. Thank you so much, everyone. Have a good rest of your day.